representing USADA here, and I'm going to give you kind of the anti-doping perspective and more so the results management side of things. So the title of the talk is The Good, the Bad, and the Ugly with Improved Detection Limits. So this is kind of the theme I'm going to outline for you. The good. So what are the good things? What are the good things that come from a lower detection limit? Then going to move straight into the bad. So what are some of the confounding factors that we face on the results management side in interpreting these low levels? And then I'm going to kind of feed right into that with the ugly. So what could be some of these causes? And some of this may be repeats from what you might have just heard, but maybe with just a different twist. So to start with, I want to set up everything with this, which is the perceptual deterrence theory. So what that theory states is that the perceived certainty, severity, and clarity of punishment are inversely related to the decision by would-be offenders to commit crime. So what does that mean from an anti-doping perspective? Well, if you have a punishment here that's distributed by the anti-doping organization, that has a positive impact on the athlete by preventing them from using bad substances. So what does this mean for us? That we have to be correct, we have to be precise, and we have to always essentially get the correct answer at the end of the day. So this is kind of one of the goals of many anti-doping programs, is to deter athletes from using performance-enhancing drugs or methods. So now, to dive into the good. So what do we want to be able to detect, or why do we want to be able to detect banned performance-enhancing substances at low levels? So these are just a few research articles if you look on PubMed. There's many more out there, and some of this work are by researchers here in the audience. And what you see is commonly we're constantly finding new long-term metabolites of misuse of various performance-enhancing drugs or banned substances. There are always characterizations of new long-term metabolites in human urine. And also, as Christian was talking about, there's always new methods and methodologies that increase our sensitivity and detection rates. So what does this actually mean? Well, it means increased detection. So what you see here is the adverse analytical findings for DHCMT, which Christian just talked about. So from 2008 to 2012, you see a total of 3 findings. I'm not sure how many samples were analyzed over that time, but we know we're in the very small percentage range here. However, after the prolongation of the detection window for DHCMT by implementation of the 3 new long-term metabolites in December 2012, you see in 2013 there were roughly 82 adverse analytical findings. So a huge increase here. Similarly for snozzolol. So again, we're looking here from the Cologne lab, and from 2008 to 2012, you'll see roughly 110 positives over that time course. However, in 2013, again, an increase to 184. So again here, we're looking at the detection window for snozzolol using a high-resolution mass spectrometry in combination with the implementation of old and new metabolites and a new long-term metabolite. So again, this effectiveness is really, the detection of these long-term metabolites, lowering that detection limit is quite effective. So I guess to keep the trend from this morning, I'm going to try to use that kind of KISS analogy here and keep it simple. So from a results management side, what do we see? So here's just a very oversimplified graph of what you might see after an individual has taken a drug or a banned performance-enhancing drug. So on the x-axis, you have concentration. On the x-axis time, y-axis concentration. And essentially, after a person ingests a drug, you would see this very large, an absorption rate, right? And if we take any of these samples, we expect to get a concentration higher as the drug is absorbed and then gradually eliminates over time. So what is that detection window that we're looking at? So let's just say previously back in the 80s or 90s or whatever it is that we want to refer to based on previous methodology, our detection window is quite small for this particular substance. Again, if these were just samples that we could have collected on an athlete, we have a very, very small window to actually detect the use of this drug in this athlete. However, with these advances, again, with these long-term metabolites, these new better methodologies, we can increase that detection window. So now you can see we have a much better opportunity or time period that we can see an athlete could have possibly used a performance-enhancing drug. So what does this kind of translate into? Well, it could be, getting back to what Christian was referring to, is anabolic steroid use and why our occurrences, or excuse me, the number of adverse analytical findings from 2017 are roughly half of all those reported. More specifically, if you look, a third of them could be attributed to stanozolol, nandrolone, and clenbuterol. So again, all these improvements in our detection methodology, our limit of detection, have increased the detectability of these anabolic steroids. So Christian kind of already talked about this, but from an anti-doping perspective, this is quite beneficial, right? So now this gives us the opportunity to retest samples that are stored. So what came from all this? Well, over here you see 101 positive tests, 82 sanctions, which equated to 47 athletes stripped of medals from 2008 to 2012. So this is, again, getting back to that deterrence theory, this can play in quite well to deterring athletes from wanting to use these performance-enhancing drugs. So what about the bad now? Are there any consequences that we face for increasing the detection window for these substances? So it's important to remember that all we're looking at here is possible a snapshot in time. So if we collect a sample at any given moment, it's just a snapshot in time. So we hope that this kind of curve exists with whatever substance we're looking at. And let's just say here, we took a sample somewhere right around here. We might see that it has a high concentration. So from an anti-doping organization perspective, you might start assuming maybe this athlete recently used this particular substance. Now, what if we take one and it just happened to be down here relative to when the athlete used the substance? Now we're looking at this and thinking, well, maybe this isn't recent use. So what if we get two samples on the athlete? What if we collected this one first, this one second? So what can we start assuming from this? Well, they used it recently here. We got them close to when they ingested the substance. We tested them again. Well, this is probably residual, so we're okay. But is that always the case? So here, we're going to kind of look at an example of maybe when this isn't a case. So right here is just a kind of brief example, again, where you have on the y-axis concentration, on the x-axis time. So we collect, let's just say, 3 samples on this individual. First sample is negative, second sample is positive, third sample negative. And it's reported at 2.5 picograms per mil. So you would assume, okay, we're good. You collect a few more samples, and they're negative as well. So you would think, okay, maybe this athlete just administered a dose once, they're good, you can administer the sanction. But then on the 8th sample, you get a quantification, an estimated quantification for the same substance, almost double of what the first was. So then you have to ask the question, did this athlete re-administer? How much did this athlete take in the first place? What's going on? You continue to take a few more samples, and you kind of see that elimination phase here. So maybe you start thinking, okay, this athlete reused, and this is what we're seeing. You do a couple follow-up samples again, or excuse me, collect a couple follow-up samples, and they're all negative. So you continue going on, and you collect multiple samples on this particular individual. And again, you're starting to ask yourself these questions of how many times did this athlete use this banned substance? Could it be 3 times? Is this a natural variation within a person? Should everyone respond this way? And also, how much of the substance was did this person consume? So what I just showed you was actually a study done by the Salt Lake City lab looking at clomiphene. So again, just to orient you, all these on the y-axis are concentrations in picogram per mil, and the x-axis is time over days. And kind of what you can see is, I only talked about subject 2, but you can look at every single subject and see how variable this is. So these individuals receive 50 milligrams a day over the first 30 days, which is kind of grayed out here. You can see subject 4, 6, 11, and 12 kind of had that peak of absorption, then elimination. Not easy to interpret if you got the wrong time point, but it kind of follows that general trend. But if you start looking at subject 1, 2, 3, and even subject 10 down here, you'll notice over those 30 days of administration, there's hardly a bleep in concentration that occurs. So from an anti-doping side or from a results management side, these are the type of studies we need to help interpret the data on these particular substances we see. So just briefly on the ugly. So are there any consequences for increasing the detection window? And I'm just going to briefly talk about SARMs just to kind of set the background. So up here are just a list of some of the SARMs, and over here are currently the clinical trial phase they're in. So SARMs are quite useful in clinical applications. A lot of them are being used for breast cancer therapy, but kind of more applicable to this audience would be the chronic muscle wasting. So conditions that they are used for are to treat sarcopenia, or age-related muscle wasting, stress urinary incontinence, DMD or Duchenne muscular dystrophy, HIV/AIDS, end-stage renal disease, burns, and cancer cachexia. So these SARMs are quite important and potent at preventing the muscle loss related to these diseases. So one key point to bring to your attention is weight loss in some of these diseases are the #1 predictor of death. So that's kind of a big reason why folks are pursuing SARMs as a way to kind of prevent and prolong quality of life for these individuals. So I just want to kind of get back to the SARMs here and talk about ostarine in particular. So if you look, it's kind of second on this list of number of cases or occurrences of AAFs, with 28, I believe, in 2016 and 47 in 2017. So why is that relevant? Well, since 2016, we've announced 22 ostarine-related cases. And although I don't have the data for 2018 from WADA yet, from 2016 to 2017, there's been 75 AAFs reported, or adverse analytical findings. So, from these cases, we're making up maybe 20% of these. So where's this coming from? Well, a potential or a possibility could be dietary supplements. So currently we've tested roughly 36 dietary supplements that have been found to have ostarine in them. Not just ostarine, but other SARMs and other prohibited substances. And these substance levels, or the levels found, can range in the microgram range per dose, meaning in a scoop of powder or per capsule. These are commonly found in supplements which target muscle building, such as a whey protein, an amino acid, etc. And since 2015, US athletes averaged 1.5 declarations per test. So not just supplements, but also medications. So why is that important? Where there have been cases where over-the-counter medications and even prescription medications could be found to be contaminated. So here's one just looking at hydrochlorothiazide that was found in the urine of an athlete. And then when they started doing some research and tracking back, they found that it was actually in the coating, I believe, of an NSAID or an anti-inflammatory drug the athlete took. So what is all this telling us? Well, contaminated medications and supplements, which we kind of all assume and know now, can lead to positive urine samples. Medications, even if they're produced under good manufacturing process guidelines, can also lead to positive drug tests. And finally, diuretics ingested at the microgram levels, which occurred here, as well as now we know steroids possibly could also be detected and cause a positive urine sample. So I'm going to kind of leave you with just a bunch of questions that we are faced and not really too many answers. So as Christian was saying, the majority of what we're detecting is down here in this low concentration range. We don't get too many of these, as it was referred to this morning, the dumb dopers, essentially these easy ones. So we're still asking, what are we looking at? Recent use, non-recent use, residual? Did any athlete re-administer, or is it having a pulsating effect? Is the formulation that these athletes are using, or whatever drug that was obtained or ingested, is an extended or delayed release formulation? Is the drug sequestered into specific tissues? So could it be stored in fat and then released at a later date as the athlete trains or exercises? Could it be contaminated products, as I was referring to with ostarine or hydrochlorothiazide? And then how do these long-term metabolites behave? So now that we're detecting at the picogram levels, is that consistent? Is it constantly eliminated? Or can it fluctuate and pulsate, if you will? So just briefly, I just want to thank the PCC again for this opportunity, Michael, Jenna, and the other crew, and say thanks.
I'm trying to find out who this other crew is that I've never heard of from the PCC.
Yeah.
Christiane, if you wouldn't mind joining Adam.
Putting my shoes on.
Putting your shoes on. Adam made you that comfortable? We've got microphones for questions. I know this is hopefully one of those difficult topics that we get to speak about. Plainly, I know Christiane and Adam did. So, are there any questions?
I have one first for you. You never put the concentrations on your axis. Were these picograms?
Picogram per mil.
Picograms.
Yep.
Okay. Yes.
Hi, this is Steve Elliott. You're showing dramatically increased detection now of SARMs and other drugs. Given this increased incidence, can you estimate now what you think the doping incidence is in some of our sports?
It's,
I mean, is it worse than we thought, or what?
well, this is interesting because when I was listening to David Howman this morning, I was kind of reflecting, what would I say? Are we better? Are we not better? I think we were successful in some athletic populations to reduce the damages, meaning that they cannot, I'm saying this and I don't even believe it all the time, but we reduce the damage. But I see this guy with a syringe doing a transfusion like in the 60s, and I'm just like, oh, come on. So the prevalence, I have no clue. But I can say that if, like in this weightlifting competition, it was 14%, which is a lot. And it's a combination of very hard work. And I'd say we were lucky in some way, because in weightlifting, they weigh before lifting. So the specific gravity of the samples, they were close to 1040. So it was, they were peeing a brick. So all was concentrated there. So this set of circumstances made the detection better. So I think most of the athletes who are tested regularly will be more careful. The vast problem that we have now is not addressed, is the availability of the new substances. The SARMs, it's sold everywhere. And since it's not, strictly speaking, on the list of what is prohibited, it's continued to be sold. And everybody, each Joe Blow can get some powder from China and prepare the gear, the stuff, so that we're good with the chest when going out there. This is horrible what I've heard lately. So this is available. I don't think top athletes necessarily are going to use this, but they may be tempted, because they advertise the SARM as it's going to be like testosterone, but no mustache. So for females, that would be very good. So you see the way, so this is snake oil, but it's there everywhere. So we have an increased availability compared to 30 years ago when it was coming from the pharmaceutical industry and diverted. So the background is worse, much worse. What we have to deal with, they suffer, is horrible. So I cannot say that athletes would not be less tempted to dope with everything that is available. So I have no clue. I'm not in the prevalence, I'm not there. I have no clue, no clue. But I do not think that we've achieved so much, but reduce, as can I say, the best we did is to manage the damage, reduce the damage a bit. For 40 years later.
John Daniso, nice presentations. I just want to comment on your point that, you know, it's from the instrument manufacturer side, we see the same, you guys aren't the only industry facing the problem with seeing everything is that you see everything. And as you mentioned, you know, when you can see in the picogram per mil level, you know, you have to be extra careful with laboratory practices. And I've run into the same thing where, you know, you make a standard, you think you're fine, and, oh, there's stuff in my blank. Or even, God forbid, if you're dealing with something volatile like, you know, methamphetamine, you could do it in a room you know, you could be weighing it out in a room, you know, 2 doors over, and it'll float through the air and get in your blank. So it is a challenge. And then, you know, with the sort of the individual variations, were those urine samples or?
Those were urine samples.
Yeah, and so that's, I'd be interested to look at the like specific gravity or some of the other factors. You know, is it that, you know, if they're very hydrated, you don't see it? If they've been working out and they're dehydrated, you may see it. So that's certainly a legitimate compounding factor.
Just one remark with what you said. When we retested the samples from the Paralympic 2010 games, well, we got a major problem of carryover with trimetazidine. At the time, it wasn't banned, and many athletes, well, we spotted the culprits, but it was a total contamination of the entire batch of samples with trimetazidine gluing in the chromatogram. So yes, we have to be very cautious, very careful.
That's another excellent point, that, you know, not only just contamination, but carryover, when we're, especially if you look for wide, you know, concentration ranges, carryover at low levels can be a huge problem. And it requires sometimes extra method validation to ensure that you're not facing it.
Quick question on the SARMs that are showing up in some really unremarkable products that are really not targeted for anabolic outcomes, like the electrolytes. Probably for the room, actually, this question. Do we have any leads on how that's happening?
If I just can say something, this is not a very kosher set of products. In my opinion, it's like a venereal disease. You don't catch it on a toilet boil. You know, it doesn't seem politically correct what I'm saying here, but if you buy something that contains Ostarine or DHCMT, it had to be somewhere in the production line, by the manufacturer or the distributor. So these are not the safe supplements that we're telling athletes to use. Never use supplements that are not tested by an NFS or whoever. These are really bad supplements. And indeed, we found Ostarine, LGD, RAD. We found ibutamoren instead of Ostarine. So this is bad production. So again, athletes must be careful. We cannot abandon teaching athletes to be careful about what they consume. I may look Christian's sister, be careful about what you're taking, but most of what we saw, athlete supplements were contaminated, not sealed products. If it was really something that had no Ostarine or no DHCMT or no LGD 4033 in the line.
We've also heard that SARMs have a high potential for sticking or having some residual. Could you comment on that?
Oh, yes, sir. Yes, indeed. But I will not comment, but because this is a very recent experience that we made, but this is the black market. What you have to realize, it's the black market. So they do things not the way that pharmaceutical companies would do it. So they can sell a product that is not soluble at all. So you have the powder floating or being sedimenting and on the bottle. So the people using it will just put a small portion of there, but it will stick everywhere after that. It can contaminate. It's same thing in your house. If you're using a medicine, a drug, and you're not paying attention, you can put all the family at risk. So you have to be careful. Yes, as anything, it can contaminate. You have to be careful, particularly if it's in the milligram range, maybe, and then you put it can stick, of course.
It is impressive that laboratories such as yours can detect these extremely low levels of these drugs. at the low picogram LODs that you talked about, say 5 or less, or high femtograms for that matter, I am concerned about the quantitation at those concentrations. So could you give us some idea of what your precision and accuracy quantitatively is at, say, 5 picograms at one of these substances? Because that comes into play when we have the second speaker talking about interpreting those concentrations in terms of use. So it's the qualitative identification with great accuracy is impressive, and certainly in some settings is enough to indict an athlete for use, because it's there and you're sure it is there, or it's metabolite. But when it comes to the interpretation and your surety of its value in terms of concentration, excuse me, then the precision and the accuracy of the quantitation becomes very, in my view, becomes very, very important. And if I was an athlete, I'd be very concerned about being accused of use in a certain pattern of use based on...
You mean reuse?
Yes,
not
and based
use,
on quantitative...
reuse.
Yeah, based on quantitations at those very, very low levels. So can you give us some idea of what the precision and accuracy of the quantitations are, say, in your hands, in your lab?
You have a bingo here, because this is a very important and crucial point. First, all what I presented is not accurate quantification. It's a rough estimation, because these are non-threshold substances. What we are now discussing is torturing the purpose of the test. The purpose of the test is to demonstrate the presence of a given substance or metabolite in a sample. What we are now trying to do is to look at that result and try to interpret whether the athlete took it, when, and how. Also, you have seen these spikes. So you've seen the excretion studies that I've presented. There's no spike. It's going relatively smooth. And it's not quantification at the third level. But in a real lab facility, you may have the lab LOD is there. You can have you're there, positive, negative, negative, and then positive. So this is due to the reproducibility or the setup of a given lab. Now, what you are discussing is not to sanction on an athlete on the first case, because the presence is there, it's confirmed, whatever the level, I would say. Then you are saying, what can we sanction an athlete for retesting positive? Is this as he presented? Second, administrations. On small picograms, I say this is torturing torturing the fly, you know, give me the answer. It's asking too much. It's asking too much. We cannot answer these questions. The only thing I can tell you, and also, as it was mentioned, a sample may be more concentrated, another one more dilute. So, and that day, the lab, the day that it's more dilute, the lab is not good. Having a bad day. The instrument is having a bad day. So you detect, you don't detect, but you should have detected. And maybe this was about the same. So you see, what I'm trying to tell you is that, well, this is what you're asking in these picograms. You're asking me, it's very precise. No, it's not precise. And the difficulty is that we are now trying to over-interpret this test result by doing pharmacokinetics. And all of us in the lab would say, we should never have started like giving the authorities these levels, because everybody is trying to do pharmacokinetics like you did, pharmacokinetics, a little more, a little less, or maybe yes, maybe no. This is not, the test is not done for that. When we provide an amount, it's to give you an idea. But now it's like, if I may say, I totally agree with you. You have no sensitivity to say that 5 picograms per ml is a dose, 10 picogram is a reuse in between. I could have killed myself looking at you saying this. Of course not. with all the analytical variation. Moreover, if you're having several labs, that cannot be. That cannot be done. So again, it's not the fault of the lab. It's the fault of the administration asking too much from the test. So common sense should prevail, if I may say. And I know you have common sense, but so.
I would like to say that we've kind of tried to interpret things with a common sense approach, knowing that at those levels, the accuracy is quite variable. And, you know, for specific substances, it may vary as well. Like clomiphene, for an example, we know it can be sequestered into specific tissues and released at later dates. But again, I think this gets back to kind of the research, the administration studies to better determine what happens to these metabolites, what happens at low levels, and how it kind of plays out.
I know there's questions now. Well, not the scientist or the journalist?
All right, so this is a
Is
lab
he a
question.
journalist?
Yes, I'm a scientist.
Identify yourself first, sir, first.
John Travis from NSF International. I actually have a question for the lab folks in general. So what we're talking about is a qualitative kind of method at these levels. So has anyone established like a probability of detection curve at the different concentrations to know what your risk of false positives or false negatives are?
For an identification?
Yes. So
No, if the criteria are met or the criteria are not met.
So at what point in time do you consistently meet that criteria 90% of the time with all your, that's what I'm asking.
Okay, so this is not done from an excretion study. We are not validating a method with 10 individuals taking the same dose of methandienone, let's say, and saying we should all detect these athletes after 20 days. No, this is not how we do this. We have the substance. Luckily, we have the standard that we inject. We spike urine samples because all athletes' samples may be different. We're not playing with a universal urine. Urine is not blood. Blood is fairly easy. It's straightforward. In urine, it's varying. So we are spiking representative urines with levels of this metabolite, and we're diluting. We're getting less and less until we cannot detect. And we have different instruments, and we have different technicians. And then we have our LODs. It's each time we have to detect to establish the LOD, the LO confirmation. We meet the criteria, which is all the ion transitions must be there, and they must be in the same relative abundance than your reference standard. And they have to elute exactly at the same time. So it is not a question of amount. In some samples, it is impossible to get lower than 10, let's say. In some others, nature's kind, you can go as 1 because it's dilute. That day we have less background. So, but when we do the validation and we say the LOD is 20, it's because all the analytes and all the data that we had show the positive identification criteria. So it has nothing to do with when the person would have taken the dope. It's irrelevant, totally. It has to do with the chemistry. When the criteria are met, we report. One athlete could have taken, because there are individual differences. For one athlete in one form, orally, let's say, it can be equivalent to 3 hours. In another athlete, that could be because it was injected 3 months, 6 months later. So, you know, it's different. And again, it's the interpretation. Nowadays, we're trying to go back to the athlete and to say, aha, you took this and that date, exactly, precisely. We know. No, we won't be able. The presence of something in a urine sample is a sign of past administration, I'd say, exposure, administration. It came in contact with the skin, with the mouth, with whatever. But it is not made. We have the picture of what's in the bladder at the time of the sample collection. But we cannot say from this, and we should not be asked to say, what was taken in what form, what frequency, what is the timing, we should, and furthermore, the intent. So we cannot, it's not a crystal ball. It's there. It's there. And it sounds crazy, but this is like having a cancer. You have a test, you have this test showing that you have the cells. No, 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 I'll have another test, less sensitive. So I'm joking about that, but this is the same thing. We should not over-interpret these test results.
Yeah, I've been asked to identify myself, so I should. Andy Brown from the Sports Integrity Initiative. Hello. And I should probably say, please forgive me for not being up to speed with the science with this next question.
It's okay. I will humiliate you with my answer. No,
that's all right. I don't mind. You go ahead. But what I wanted to ask is really, obviously, labs around the world are being asked to detect very low levels now, picograms of substances in urine and blood. And I suppose the simple way to ask this is, are all labs at the same levels of detection? Because, you know, if I was an athlete, I would perhaps hope that my sample might be sent to a far-flung corner of the world where the detection methods might not be as great as in, say, Cologne or, you know, one of the other labs.
Oh, Montreal. Say Montreal.
Montreal. There we are. But you get my point, though. Are the labs
absolutely.
Are the labs all at the same level, or is there a differentiation between who has the high level detection equipment or not?
Yeah, of course not all the labs are equal. And this is something, it is a myth, it is a fantasy that I'm hearing for 30 years. We have all to be equal. To be equal, we have the MRPL. Everybody can see a ton of it. Yes, sure. We are all able to do this. And this is also a good first step. And WADA is working in improving all the labs so that we are more, let's say, equal. But it's always a compromise. What we do in my lab, what they do in his lab, what they do in his lab is different. We have a compromise. We decide to be very good, very sensitive for steroids because we figure out that it's where we have to be more, we will be more useful. But no, not all the labs are the same. This is why the samples are getting everywhere in the world now. They go there, they go at the other lab, and in some labs, apparently, they were throwing the sample in the sink so that they were not testing. So this is the best way to evade testing. But this is why also athletes are not getting to decide where they are tested. So and this is why the B sample must be done in the same lab. Because if you are, let's say, athletes, I don't know if they're true all the time, but for sure they will say, oh, if we go to this lab, we're going to get killed, so we are more careful, we stop. The withdrawal period is 1 month sooner, and then if they go elsewhere, we can try our luck, and they will be caught positive. You never know. We have now, this is why there is retesting. So no, not all the labs are good. Some of them are better with EPOs, some of them are better with DHCMT. And all of us are good, but not for all at the same level for all the same substance. But I can tell you, compared with where we were 30 years ago, we are vastly, the labs that are here can be trusted. They are much better than where we were 30 years ago.
Other questions? Everybody really wants coffee. Okay, thank you to our speakers.